I'm Dave Marshall. I'm a radiation oncologist at Hollings Cancer Center at MUSC. I'm going to talk a bit today about low-risk prostate cancer and the management options that you have to take care of this disease. Low-risk prostate cancer patients should understand that you're not likely to die of prostate cancer no matter what you do. So you have time to make decisions. And that's what this educational video is about, helping you make those decisions. There are many options and ways to manage low-risk prostate cancer. Many patients with low-risk prostate cancer never need treatment. So one of the things we do for low-risk prostate cancer is something called active surveillance. Active surveillance is following the cancer, monitoring it, and then initiating treatment if the prostate cancer progresses. But many patients can go years or even forever without that happening. Active surveillance is the process of following PSAs and a physical exam every year and repeating a biopsy. When you add your biopsy, the urologist usually does about 12 samples, and that's how we get the Gleason score. The Gleason score is how the prostate cancer is graded by the pathologist. The faster growing the prostate cancer, the higher the Gleason score. Most people with low-risk cancers, or all patients really with low-risk cancers, will have a Gleason 6. That's the lowest grade that we even call cancer. So that is a Gleason score of 3+3, or it's also called a grade group 1. So patients with this slow-growing type of prostate cancer, it's diagnosed with that biopsy that you've had. We need to repeat that biopsy in about a year if you're on an active surveillance regimen to make sure that we didn't miss something the first time, to confirm the findings of the first biopsy that it is indeed the low-risk prostate cancer that we think it is. We also watch the PSA every 6 months or so. We'll check a PSA and do that physical exam once a year. And then if nothing changes, we can continue that process for years without ever having to initiate treatment. Now, if you have progression under active surveillance or you have a change of heart and you decide you want to do treatment, there are other definitive treatment options to choose from. The ones you'll hear about most, or the most common, are surgery to remove your prostate or radical prostatectomy, external beam radiation, which is done with x-rays or in some locations protons, or brachytherapy, which are seed implants or also called HDR brachytherapy, which uses temporary catheters to deliver a radioactive source in and around the prostate. So I'm going to talk today about the options we offer here at MUSC and Hollings Cancer Center, and that'll be radical prostatectomy, external beam radiation, or a seed implant form of brachytherapy. So radical prostatectomy is the most invasive approach to treat prostate cancer. It's a surgical procedure that can take about 4 hours. You usually stay in the hospital 1 or 2 days. You go home with a catheter placed in your bladder so that you can heal. That catheter stays in place for a few days to a week or two while you heal up, and then the catheter comes out. Biggest issue with the surgery to remove your prostate is that it is an invasive procedure, and they're removing part of your plumbing and then putting it back together. So the surgeon removes the prostate in the surgery, and part of the urethra, the tube that connects the bladder to the outside, is removed. And so that has to be hooked back up during the surgery, and then you have to heal up for a while after that. So the biggest risk associated with surgery is really urinary incontinence or leakage. Anywhere from 5 to 15% of patients will have to wear a pad or a diaper forever after that surgery. So most people don't have to have a pad or a diaper, but there is a significant risk of that happening. When they remove your prostate, they have to pull the bottom part of the bladder down to connect it to the remnant of the urethra, and that can change the dynamics of the bladder and bladder function. So there are some bladder changes that people can notice after the surgery. Usually they're bladder urgency or having to rush to get to the bathroom, a sense of urgency that you need to go pee. This usually gets better over time, along with most side effects from any of these treatments. So surgery is the most invasive approach. It removes part of the plumbing, they have to put it back together, but it is over in a day, and then you heal up for a period of time, and the side effects usually generally go away as the weeks go by. External beam radiation is another common approach to treat low-risk prostate cancer. And I should say that there's no difference in cure rates between any of these options, whether you have surgery or radiation in the form of external beam or a seed implant or other brachytherapy. The cure rates are very high, upwards of 90% chance of the cancer going away and never coming back. So if you choose external beam radiation therapy, this is the least invasive approach. You lay on a table, the machine moves around you, and over a period of about 5 minutes delivers x-rays in and around the prostate area and the pelvis. Then you get up and go on about your day. It can be every day, Monday through Friday, for anywhere from 4 to 6 weeks. So it is more of a process than the surgery to remove your prostate. The side effects associated with radiation, especially external beam radiation, are generally mild for most people. You don't feel anything when you get the x-ray treatments, but after a couple of weeks of treatment, folks may start to notice that they have some bladder irritation. Whereas with surgery, the bladder irritation was in the form of frequent urination or urgency, feeling that you have to rush to get to the bathroom. With radiation, it's more obstructive symptoms. We're not removing the prostate, we're treating the prostate in place, and it can swell a little bit during the treatment so that you could have weaker streams, stopping and starting of your stream, having to get up in the middle of the night more frequently, things like that. These types of problems are addressed usually pretty effectively by medications like Flomax. So these tend to start up during the middle of the radiation treatment and come to a peak towards the end, and then persist for a couple of weeks after the treatment is over, and then they slowly fade away with time. You can also have bowel symptoms with radiation that can cause you to have more frequent or looser bowel movements. Again, this usually starts after a couple of weeks of treatment and peaks towards the end, and then slowly goes away after we finish the radiotherapy. We do many things to minimize the risks of these side effects and toxicities, but most people get some of this. It's not usually debilitating in any way. You continue with your daily routine, except you have to come in every day and give us that time to do your external beam radiation treatment. Another option for treating prostate cancer is a seed implant. That's an intermediate between the invasiveness of a radical prostatectomy and that of the external beam. So the radical prostatectomy or removal of the prostate is the most invasive approach to treat your prostate cancer. External beam is the least invasive, and a seed implant is in the middle. A seed implant is done in an outpatient setting, takes about 2 hours under general anesthesia, but you go home the same day. So we use long skinny needles to place the seeds in and around the prostate while you're asleep. And when you wake up, you have a little bandage down in your perineum that comes off the next day. You go home that day as soon as you're awake and alert from the anesthesia. The seed implant then delivers its radiation through the decay of the radioactivity of the seeds we put in your and around your prostate over the next few months. So the side effects from the seed implant are a little bit more intense than those of the external beam. So you may have some bruising or some swelling from us poking holes in your perineum and placing the seeds in your prostate. You may see some blood in your urine or your bowel movements for a couple of days, but it usually heals up pretty quickly. The types of side effects from the seed implant are similar to that as the external beam, but they may be a little bit more intense on average. The radioactive sources are placed directly in and around the prostate, and the dose is quite strong, so the bladder irritation is a little more intense. That is the weaker stream, stopping and starting, maybe some burning when you pee. Those things are usually a little more irritating with the seed implant on average than with the external beam. Now remember, everyone who has a prostatectomy, who has their prostate removed, has to have a catheter for a week or so after the procedure. With external beam, the swelling is usually minimal, so that only about 1% or less of patients will need a catheter to help them empty their bladder with external beam radiation. The seed implant is in between. Again, it's not as invasive as the radical prostatectomy, but it's more invasive and a little more intense than the external beam radiation. And there's about a 1 in 10 chance that you might need a catheter to help you empty your bladder if you have the seed implant. So the benefits of the seed implant are it's done in a day, and it's less invasive than with the radical prostatectomy or removal of the prostate, so that you don't have to make as many trips back and forth as you would with the external beam. So they all have pros and cons. Now the radiation side effects from the seed implant and the external beam are going to be similar in nature. The intensity is a little more with the seed implant, but in general you'll have stopping and starting, weaker stream, getting up more in the middle of the night, those types of things that we often treat with medicines like Flomax or tamsulosin. These things will peak during the course of treatment or for a short period afterwards and then slowly fade over time. So that most people by a few months to a year or so after the treatment have gone back to baseline. Their bladder function and bowel function have gone back to what they were before treatment. Now, there are some things that you can see with radiation, whether you have a seed implant or external beam, that can show up as the months or even years go by afterwards that have nothing to do with the cancer. So the radiation could cause you to be able to see a little bit of blood in your urine or in your bowel movements as the weeks or months go by after radiation. Now, this is not from the cancer, but it may be from some scarring or mild injury to the lining of the bladder, the rectum, that's caused by the radiation. This happens with external beam about 5 to 10% of the time. You might see some blood in your urine or your stool. Most of the time, if you see it in your bowel movements, it's from a hemorrhoid and not related to treatment. But if it keeps showing up, we need to check it out and make sure we're not missing something like a polyp in your bladder or in your colon. So we'll do a scope and make sure that we know exactly where the bleeding's coming from. Most of the time, even if we see that there's some scarring from the radiation, it doesn't require any treatment and we'll leave it alone. The other thing you can see from any treatment for prostate cancer, whether it's a seed implant, external beam, or radical prostatectomy, is changes in sexual function or problems with erectile dysfunction. So it's most common, especially with men with low-risk prostate cancer, after surgery compared to external beam radiation, but they all have that risk. There's all a significant risk of having more problems with erections after treatment for prostate cancer than before, whether you have surgery or radiation to treat your prostate cancer. So it's definitely something to think about. However, there are multiple ways to help with that problem, not just the pills that we've all heard of, but other things as well. And so we have specialists that can help a gentleman with that problem, regardless of why they have the problem or how they got the problem. With radiation, unlike surgery, you can have a risk of something showing up as the years go by afterwards. It's uncommon, but exposure to radiation in general is not good for us. We know that from atomic bomb survivors or Chernobyl survivors. So if you get a big exposure of uncontrolled radiation, it's possible that could increase your risk of having other cancers, leukemias, thyroid cancers, things like that. So with external beam radiation or a seed implant, theoretically, that treatment for your prostate cancer could increase the risk of you getting another cancer down the road. Now the risk, thank goodness, is really small. So if your risk without radiation is X, whatever that risk is, X of getting another cancer in the next 5 to 20 years down the road in your pelvis, with radiation, it may increase to X plus 1 or 2 percentage points. So it's a small increase in absolute risk. It doesn't mean you will get one, you probably won't get one, but it may increase your risk slightly. That's different than surgery. Now, whether you have surgery or radiation, there's a small chance that you could have a really bad outcome. With radiation, it's possible that you could have an injury to your bowel or bladder that could cause chronic pain that would require pain medicine, or severe bleeding that could require transfusion, or an injury that could require surgery to fix a problem with your bowel or bladder. It could even result in a colostomy. The risk of that happening to you, though, is less than 1%. About the same risk as having a catastrophic problem with anesthesia with a radical prostatectomy. So thank goodness the risk of anything really bad happening is low. However, it's not zero. That's why if you have low-risk prostate cancer, you should always think very hard about active surveillance, about avoiding definitive treatment until this cancer shows us that it's going to progress and maybe cause a problem down the road. Because again, remember, almost no patients who start off with low-risk prostate cancer die of prostate cancer, no matter what they do to manage their disease. For prostate cancer, it's very important that every patient hear about all these different options that you have, because there's not one best way to treat prostate cancer. Some patients may be best treated with surgery, some with radiation, some with a combination of seed implant, etc. So make sure that you talk to your urologist and you talk to a radiation oncologist about all these different options. You need to be an educated consumer when it comes to figuring out how you're going to manage your prostate cancer. At Hollings Cancer Center, we truly believe that the best cancer care comes in the context of a clinical trial. No matter where you get treated, ask your provider, how can I participate in a clinical trial? Because that's how we improve cancer care for ourselves and for our future. If you need more information about how to care for your prostate cancer, reach out to Hollings Cancer Center. We're here to help.